I'm delighted to be here and to talk with you today. I'm going to ask to hold questions and discussion till the end if we can. And often I love being interrupted and just getting into different things, but I really want to try and put out a smorgasbord of what we've been thinking about over this past 7 or 8 years of the research program, so that you'll have this overview and then we'll get into discussion afterwards. Again, I would like to echo the words of Dr. Shannon and acknowledge that we are on the lands of the Coast Salish peoples, including the territories of the Musqueam, Squamish, Tsleil-Waututh, and Tsleil-Waututh nations. My own disclosures, I've had funding for post-abortion, and we may get a chance to look at some of those contraception trials where the devices were donated by industry, but UBC spent about a year and a half negotiating a contract that completely guaranteed us academic freedom and made sure that they didn't have the choice to shut it down any aspect of what we had wanted to do for their design. So most of our research is funded through government and nonprofit organizations. Gender equity and fertility control. This is what we'll be pondering on over this next 40 minutes or so. As you may be aware, families and people and populations who are able to time and space their pregnancies to actually set their own reproductive goals, whether and when they would like to have a birth, are able to achieve a wide range of social, economic, personal, community, and workforce benefits. Females, biologic females, are better able to complete their education when they can manage their fertility, participate more fully in the labor force, have increased productivity and earnings, and enjoy higher household savings and assets. And this actually translates into better child and family health. Children who are intended, and families where all children are intended, are better able to ensure food safety during the time those children are at home, to ensure that there's adequate shelter. There's shown to be less violence in the homes where the children are all intended, and those children have a higher rate of graduating high school and succeeding in their own lives. So very intergenerational effects. Conversely, when we look at populations of people with unintended pregnancies, we see a concentration of those with the poorer social determinants of health. Unintended pregnancy is very common, and it's particularly disproportionately common amongst people who have the least resilience to be able to deal with subsequent unintended pregnancies that might proceed to either abortion or birth. There's a wide range of literature, and I've just selected a very few points here of those in populations that are vulnerable or disadvantaged, that are facing inequitable social, sexual and reproductive health, and the association of those inequities that's compounded with unintended pregnancies. So over these last 40 years, since we have had some hormonal fertility control options available, we've had a vast change in the reproductive epigenetics and reproductive epidemiology. And as you can see in this data that's looking at people who were born in up to the mid-80s, and when they had their first sex, when they had their first planned birth or first live birth. And in the United States data that we're looking at, you can see that people's first intercourse is around 16, 17 years of age, and the first birth, mean age at first birth for the mother is about 26. In BC right now, our mean age for first intercourse is about 16 and a half to 17, and our mean age for first birth crossed 30 2 or 3 years ago. So we've got people that are facing half of their reproductive lifespan, more than 15 years, not wanting to have their first birth, and a number of years after that where they would want to be spacing between pregnancies or avoiding pregnancies. And typically, people are using methods that have a 5 to 10% rate of failure a year. So when you use the tier 1 methods, and we'll be talking about tier 1 or long-acting reversible contraception in different parts of the talk today, you can see that people will have less than 1% of pregnancies in a typical year of use. Whereas with pill, patch, ring, or Depo-Provera, are tier 2 hormonal contraception methods. You can expect people will have 6 to 9% of people will become pregnant each year using those. And again, think back, we're talking about a span of 17 years before you want to have your first birth, and a number of years between your births after that. And of course, those using barrier methods, which is in some cases is the majority, have upwards of 12% to 24%, depending on their method. Why is this, and what other inequities face people? The difficulty is that the higher tier methods, the more effective methods, are more expensive. And so, again, if you are disadvantaged already, and particularly economically disadvantaged, maybe you're disadvantaged in terms of access or knowledge, you will be able to access more easily the less effective contraceptive methods, which will lead to higher rates of unintended pregnancy. It is much more expensive for consumers to pay for the most effective methods. Now, when we look at the health system, however, health systems are paying for the cost of managing pregnancies. So it far exceeds the cost of contraception. And for the health system, the least expensive contraceptive is the one that's going to work best. And in Canada, the best working contraception is about $400 a piece. In the United States, the same thing sells for $900. So our health system pays to manage any pregnancy, but not the cost to prevent pregnancy, which can be a major barrier, particularly among disadvantaged populations who are already facing a range of inequities. Countries around the world that provide a health system and care for pregnancies typically are providing universal subsidy for the prevention of unintended pregnancies. So why aren't we doing that in Canada? There was a wonderful article in Millbank Quarterly that came out a couple of years after Obamacare was implemented in the United States, which included free access to contraception with no copay and to contraceptive counseling, so people could access the knowledge they needed. And the return on investments, and I want you to keep this in context here, some of our best return on investments in population health happen with initiatives such as vaccines, where we'd expect a return between $1 and $4 for every dollar spent on vaccines. That's considered like over the top. And many of our health interventions, if you could just come to even and not have additional dollars saved, that would still be reasonable because you're getting better health outcomes. So you invest in contraception and contraception counseling, you save $7 for every dollar invested in this detailed analysis done of the results in the United States. What would governments need in order to be able to make this decision? You have to understand what you're already spending to manage unintended pregnancies. That means you need to understand among those who have been recently pregnant, what was the intention at the time that pregnancy started? And among those currently in your population, are they using contraception? Are they intending to become pregnant or not? And if they're using contraceptives, which tier of methods are they using? What's the likely failure rate they'd be facing? And what are the barriers to helping them to achieve their own goals? Particularly, you want to be able to relate all these factors to social determinants of health to guide health policies and interventions that will help increase equity and help people manage their own fertility and achieve their goals so that they can advance their equitable positions in the population. None of these indicators are collected in Canada. And most of those countries where you saw contraception was subsidized are regularly and uniformly collecting these indicators. So really, you need a way to measure population sexual and reproductive health and collect indicators that will help to support sexual health equity, in particular with relation to unplanned pregnancy. But actually, sexual health indicators are needed on a wide range of sexual health behaviors and care needs that are related to the equity and gender equity. Interestingly, in Canada, for 100 years, we've had public health funding aimed at TB and sexually transmitted infection. Let's get on top of TB and sexually transmitted infection. And we've got agencies all over the country. We've got laws on mandatory reporting, mandatory treatments, and still The Public Health Agency's most recent reports indicate they have no idea of the prevalence of sexually transmitted infections and bloodborne infections in the country, that the reporting system is inadequate, and the recommendation is the most likely way to get representative indicators would be undertaking sexual and reproductive health surveys among the population. Because if you can't measure it, it's not going to get fixed. And we aren't going to be able to address these inequities and particularly reach out to those disadvantaged populations. So policy leaders and health system services need this data. And Canada has been called out by the UN High Commissioner of Human Rights. The Committee on the Elimination of Discrimination Against Women has slapped our wrist and said you are not providing equitable sexual and reproductive health policies and care across Canada. So what would it take to measure sexual and reproductive health? We want to do a survey. And we assembled a phenomenal team, and I must acknowledge particularly the pushing and engaged leadership of Perry Kendall and Bonnie Henry in their roles as the Chief Provincial Health Officer in guiding this, as well as my dear mentor, Dr. Jeannie Shoveler, who wasn't able to be here today, but really picked me up when I was what I would describe as a curious clinician, wondering whether I should get engaged in research, and took me under her wing and really fostered much of my confidence to advance and do these things I'll be talking about today, and a range of other famous people you can see there who do fabulous work. We looked to the gold standard surveys that happen around the world on sexual and reproductive health. They're done iteratively. They've been done for 20 years. The U.S. one is now done continuously and breaks off aliquots every couple of years. The data is freely available from the CDC Atlanta. Anybody can analyze it, and we can use their instruments. We developed a questionnaire instrument, being able to use these validated measures that I've shown you and others. We pilot tested it for a couple of years, and then we implemented in 2015 distribution across the province in a representative sample of the population. These are the different instruments we had taken questions from. This is a computer-assisted personal interview survey with the most sensitive questions, many of which were repeated, in the audio computer-assisted self-interview section. Very confidential, using the highest standards in the categories that you see there, distributed in a representative sample of LHAs all through the province, where we oversampled for those in the neighborhoods that were below the mean for social determinants of health and income, and oversampled among those under 30. So we sent a lot of letters out to prospective neighborhoods, and then we sent surveyors door to door to a lot of homes, and we were able to identify reproductive age female, biologically female participants, about 2,000 in the sample that we were able to get, and 75% of them participated, completing the full survey, including over 80% in rural areas, which really floored me. You know, I imagine opening my door in a small town and having somebody in a bright vest with UBC sexual health written on it saying, "Can I ask you about your sexual health?" And they really, our surveyors had to do these representative samples in chosen houses in chosen neighborhoods. But in many of the small towns, the women were getting them in the street and in the grocery store and saying, "We want to tell you, we want to let you know what we need." So we were very pleased also in being able to look at the results, and this compares to Statistics Canada's new plan that all of its population surveys are going to go to online platforms or random telephone dialing. We were able to really penetrate into some of the hard-to-reach populations and to demonstrate that our sample was representative on a broad range of equity indicators among those who are disadvantaged. So what did we find? Well, not surprisingly, when you think in BC and Canada, people who are biologically female typically have under 2 pregnancies, under 2 births over the course of their life. So they're spending fewer than 5 years intending to become pregnant, and postpartum. And so across the lifespan, there's a very small portion of the time of females where they are actually intending to become pregnant. This was reflected in the data that we got. And I just want to point out, these are 5-year age groups except for the age of 14, which is just the 1 year in that age group. However, not all of those people who we were asking about those intending to be pregnant were at risk of getting pregnant. So, for example, almost none of the 14-year-olds were sexually active. Great finding. And many of the people might no longer be fertile or not sexually active. So in this, we see in the 5-year age groups, the proportion of people who were fertile, heterosexually active within the last 6 months, and not intending to become pregnant. That's our orange section there, and that's the denominator for all of the rest of what I'll be presenting on the ability to prevent pregnancy when you're at risk of pregnancy and don't want to be pregnant. So again, reminding you the Tier 1, Tier 2, and Tier 3 contraceptive methods. And this was how it played out in BC. You can see we've got a good portion of people who have permanent contraception or other Tier 1 methods. This is actually probably about double what you see in many provinces across Canada for Tier 1 reversible methods. About 20% of people, 1 in 5, are using a hormonal contraceptive, and large portion of people are using condoms alone and no other contraception or withdrawal. With 8% of the sample overall who did not want to become pregnant but were sexually active and fertile, using nothing at all to prevent pregnancy. When we break it down by age groups, it's even more distressing. You can see that those with the highest fertility are the least likely to use an effective method. And as the fertility drops, your method effectiveness is increasing. When we take away the dark green portion of the population, people who've chosen permanent sterilization and thus are not at risk now of unintended pregnancy, and look overall, we can see that most people are using a method with a failure rate of 12% or higher to prevent unintended pregnancy, and this is leading to pregnancies that are unintended. So we also asked among people who've had a pregnancy before what your intention was. We had over 90% of people complete all questions. This was done in the confidential audio self-entry form, and 40% of pregnancies were unintended. And among pregnancies that were unintended, the most common outcome was birth. And this was more common if you were socially disadvantaged on 2 or 3 or 4 axes. So the more you had poor social determinants of health you had, the more likely your unintended pregnancy would lead to birth, even though you would be the least likely to be resilient to manage the life of that child and carrying the care for that child moving forward. So we were, I must say, I was shocked, and I think our team, at the disparities between those with intended pregnancies and those with unintended pregnancies. We made graphics that we can help the health system decision makers access the data better. So really we had an excellent survey that was rigorously conducted, and we found major inequalities with unintended pregnancy, both resulting in birth and abortion, concentrated among those with the poorest social determinants of health. We brought together all this data and developed a cost-effectiveness model through a process led by Sterling Bryan on our team, and with input from Stephen Schechter at the School of Business, and conducted largely by our postdoctoral fellow, Saeed Samadaloui. We made a really interesting discrete event simulation. It cycled on everybody's, a female in BC's monthly menstrual cycle, and it included what are all the factors that would happen during a monthly menstrual cycle that would contribute to whether or not the person would be pregnant at the end of that, and what would be the outcome of that pregnancy. And so and to be able to take that what happens in a month and make it extend over a year, and then make it extend over 5 years, very complex modeling, and then bring it up to the whole population level. So it was a 3-year project to input and develop these things for the model, using all of the details from the survey as well. So we found actually that in the model, people choose a high-quality contraception when it's free. And when we modeled what would happen if the BC government were offering contraception free compared to it being a cost borne by the health system, we modeled in 2 ways. Our solid line here is for all people of all all females in BC, and the dotted line is if it were only offered for those under 30, with the red line being the baseline of pregnancies, and this is showing the percent reduction in pregnancies. So within 4 years, we're seeing more than a 12% reduction in pregnancy, in the total number of pregnancies in BC. And we were able to break it down by the sectors that would be bearing the cost of the contraception, of the health services, of the hospital services. And when we put together the cost here in the dotted line for the costs of pregnancy going down right from the beginning, the costs of contraception going up from the baseline, and looked at status quo as being the red line, we can see that within the second year, we are already saving costs. And those savings are continuing to accrue, particularly when all women are offered free contraception through the end of the 4th year. And because the devices for the long-acting reversible contraception can last between 5 and 10 years, we would expect to see increasing accrual of those cost savings. So what we learned was that a large proportion of pregnancies are unintended, 40%, more than half of those go on to birth. Then those are more likely to go on to birth in the populations that are least able to support that unintended child. And that contraception subsidy is a cost-averting strategy that would improve health outcomes, according to the modeling. We had the trust of the government because we had worked with them on another trial where we'd taken post-abortion contraception, randomized controlled trials, where we enrolled people at all of the abortion facilities in BC and attained their permission to access the health administrative data for the following 5 years to count pregnancies related to the contraception you accepted the day you had your abortion. So it required no follow-up at all from the patients, and we were able to go into the linked health administrative data to find comprehensive information on complications and subsequent pregnancies. We wrote a lot about it. We validated that we were able to capture abortions at a very high rate because we had the clinical charts for all the people we enrolled, and all those abortions appeared in the data. So we felt fairly confident. The other piece of data we needed, of course, was birth, but we actually feel confident that we're counting births okay. And what did we find? We found that, first of all, and when we made contraception free for people at the time of abortion, we changed from a 7% uptake of long-acting reversible contraceptives to a 70% uptake in the trial of long-acting reversible contraceptives, and those people had very few pregnancies. And this is an intention to treat, so we don't really care if the IUD is there or not. We're just counting how many people got pregnant. So these are the outcomes of pregnancy within 2 years after an abortion, 13% if you had a copper IUD, 5 and a bit % if you had a hormonal IUD. And almost half of people who left the center with some other plan for their contraception, who didn't start a pill or have an IUD, started while they were in the center where they had their abortion, had a subsequent pregnancy within 2 years. And the proportion of those that went on to abortion were more likely the less effective the contraceptive plan was. Or conversely, the proportion of births was highest among those with the best contraception, which indicates an intention curve. That within 2 years, these people with an average age of 27 were probably, their portion of them were intending to become pregnant. Yep. So we modeled this too. And
Code gray for the cardiac lab ECG pagers. Please manually page. Code gray for the cardiac lab ECG pagers. Please manually page. Code gray for the cardiac lab ECG pagers. Please manually page.
I learned the other day that code gray means that some system has failed. So we did a Markov modeling using the data that we had from the trials and the linked health administrative data, and learned actually that you could reduce the number of subsequent pregnancies within 2 years after an abortion by half if you gave everybody free contraception, and that this would reduce overall health system costs by 24%. This was our modeling. We gave it to the government. They implemented it about 9 months later with funding through BC Women's Hospital, and it was in place by the beginning of 2017, and they asked us to do the evaluation. So a year later, we learned that they're implementing in facilities throughout the province, covering about 70% already of the people having abortion, and that the uptake of Tier 1 contraceptive has gone to 54%, and that from our previous work with the linked data, we can anticipate that this uptake of Tier 1 contraception will be corresponding with a 39% reduction in what would have been subsequent unintended pregnancies if people didn't have the option of having this coverage. So that's what we're doing to help enable some equity. We've got a couple of minutes, 12 minutes, I guess, before going to questions. So I just wanted to move for a while into an opportunity we had to be able to address equitable access to abortion care to manage an unintended pregnancy that's unwanted. We undertook a national survey in 2013 looking at all practices of 2012, and we were able to identify that across Canada there were under 100 facilities that were providing abortion, and that those facilities who responded to our survey provided more than 90% of the abortions that were collected by CGSHE each year, so a very representative sample, and that we were able to identify 270 physicians providing abortion. At that time, only physicians could provide abortion anywhere in Canada. That abortions were provided surgically in Canada, 96% were surgical. This is not a map of where abortions are provided in Canada. You can't actually, in many provinces, including BC, legally show where abortions happen. There are various laws meant to protect patients and providers that prevent the public disclosure of abortion. But this is census metropolitan areas in the dark red, and 90% of the abortions we were able to detect were offered and provided in census metropolitan areas. Now, this is not where 90% of the population lives, and because BC has an anomaly in Fraser Valley where no surgical abortions were offered at all, we actually were able to identify that more than 54% of the reproductive age population lived within places that did not offer abortion care in BC, and similarly across Canada. So how could you address the need across Canada with these vast geographic disparities? Well, in fact, if you could give abortion in primary care, and if you didn't need surgical skills, if you could do this with a pill, that could theoretically address the massive geographic disparities we have for rural and remote populations. However, nowhere in the world has been able to do this. Everywhere in the world that they have the medical abortion pill, it's given usually in centers that offer surgery or by people who are subspecialized, or it's in specialized clinics. That's how it's rolled out. And it's because when it first came to France, it was very stigmatized. It was given a very small regulatory box. It has to be done in a certain way. And indeed, when Canada brought in regulations, they also gave a very small box that would restrict really the ability to offer this product to those who are already purpose-specific abortion providers, probably in surgical clinics or in at least in big cities with high-volume abortion practices. So very much precluding primary care regulation. Now, we had identified from our 2013 survey that this was a need, and so in 2014, the year before Health Canada made these approval for the medical abortion pill, our team nationally had got together and sat down with the home for primary care providers of sexual and reproductive health, and the place where healthcare professionals go to get their education and where they have their professional support for primary care would be the College of Family Physicians or the College of the Society of Obstetricians and Gynecologists, and in fact, in this case, because pharmacists are involved, the Canadian Pharmacists Association. And SOGC was very involved already in getting ready for MIFEPRISTONE to be introduced. They'd set up guideline committees so that there'd be guidelines in advance of the approval so that people could know what best practices should be. But the College of Family Physicians and the Canadian Pharmacists Association at that time hadn't been coming up as readily. And our team reached out, and recognizing the work of Dr. Judith Soon in the audience here in collaborating and really being a great voice with both regulators and the professional associations for helping pharmacists to make this transition to care, and to the College of Family Physicians. And we were invited to give evidence briefs on why this is central family practice, and the executive of the college debated, I'm told, a fair bit, and decided that they would stand behind all Canadian family physicians, 35,000, to say this is core family medicine. This is normal reproductive care, and that was a big shift and going out on a bit of a limb for the organization. So they worked with SOGC and with the Canadian Pharmacists Association and to go to Health Canada and say, listen, if you're going to approve this, the training should be with us, because we are the home for training and accreditation for primary care providers. And this is a big difference from what's happened in any other country, where the training and accreditation happened by abortion professional associations. So it happened with specialists that were already set up with bulletproof glass and two-way man-trap entries and all the things that surgical abortion providers do because of the stigma and the danger of providing in those settings. So we felt this was a key way to move this out into primary care. But then the regulation came out with these awful, with these perhaps limiting restrictions. We set up a program of research. I've talked a little bit about our abortion provider survey already. We immediately, when the announcement in July 30th came out that MIFEPRISTONE was approved, we were able to get in a FISI at the September 6th application for a CIHR Partnerships and Health System Improvement Grant, working with the colleges and with the governments to be able to design a program where we learn how can we support the move into primary care in Canada, and is it possible? And since we've been funded to do the same for nurse practitioners a year ago, and just a month ago we found out that our funding to do the analogous survey again, now among surgical and medical providers across the country, will be undertaken by one of our Rising Star junior investigators and her Rising Star colleague in Quebec to find out what the change has been and to map this out. And a couple of days ago, we've put in for being able to support midwives, as well as a linked health administrative data analysis for proposals. And recognizing Laura Schumer leading on the linked health data proposal, which is the main piece of her Michael Smith Scholar Award for this next 3 years, which we're very proud of. Midwifery offers wonderful opportunities to access populations with high gender inequity. We're very excited. Midwifery provision of family planning means that midwives could go to street entrenched populations or those in homeless shelters and be with them through the time of having a medical abortion, where no other provider is going to give you a pill and send you off, not knowing where you'll be able to care for yourself or who will be there if you need someone. Midwives have a lot of work in going to where people are at, and that's so important, I think, for many patients that are, many people in populations that are challenged. I wanted to recognize for a moment Jeannie Shoveler's importance in my life, taking me, as I mentioned earlier, from being a clinician to really being an engaged clinician researcher. And Jeannie helped me found a BC-based team with a core of clinician researchers in a strong, engaged group of academic researchers. And through working with BC Women's Hospital and Dr. Dorothy Shaw, many of you will know, we were able to get the leadership of the health system and then their introduction to government very early on as we were planning some of these studies. And it made a huge difference to be able to engage people like the Chief Provincial Health Officer or the lead in the Population and Public Health Division or the head of BC Women's Hospital in a discussion on what are the priority questions to address and how can we go about this? How should we be analyzing the information that we're achieving? So it's a model then that was very successful in BC. And after about 2 years, Jeannie came to me and said, you got to take this national. You go find people out there across the country. So we did. And we have a marvelous team of people that have been working on the MIFEPRISTONE, and recognizing that this is the postdoctoral fellowship work of Dr. Sarah Monroe, who's been an amazing knowledge translation specialist in being able to engage and move through meeting the dozens of requests that we get to provide evidence and to engage with the knowledge users. So we took clinician researchers and academic researchers from BC, Ontario, Nova Scotia, and Quebec, who identified each in their areas, the knowledge users and the governments and the people who would translate and use the policy. And then all of us worked together to connect with national and federal decision makers to be able to undertake this research. And we've been just delighted. People agreed on a question: how do we really move this into primary care? We got excellent theoretical frameworks, and we did it rigorously. And we had great objectives. We really wanted to understand what was going on, what are the challenges, and then we created a platform to support frontline health professionals that may never have done this before. But through the platform, it let us know what their concerns were and meet those needs, so that while they're telling us what isn't working, we're working to change what doesn't work and make it better, and then find out how that worked for them a little bit. And then integrated knowledge translation. So all of these different components then of the work that we were doing. These are the barriers that I showed you before that came out again when we held focus groups and discussions in stakeholder conferences. And a little bit about our online platform. I'm finishing up in 2 or 3 minutes. We're getting close. Where we engage people from across the country who are interested to learn about abortion provision. And so it's open to anybody with a health professional license to practice. We developed lots of tools, and you can see here, locate the pharmacy and get the training you need. And now there's additional buttons on our current one to be able to get a quick checklist people had asked for. What can I do in a primary care visit to ensure I haven't missed something? So we spent about, Sarah led for the prescribers and Judith for the dispensers, the development of a tool that a primary care person who'd never done abortion before could use to make sure they hadn't missed anything, and went through focus groups. And Health Canada liked it so much, they said, you can't put that behind any kind of a wall on your site. You've got to make it available publicly. So they've put it on their Health Canada sites, and they've made sure that the industry who sells the medication has it available on their sites. So we're really pleased with the engagement. People can get an interactive map. If you touch on any of these buttons or type in the postal code or the name of your town, it will come up with a Google map of your place and tell you the pharmacist's phone number and the hours the pharmacy's open and where you can get the MIFEPRISTONE. So those things, as well as being able to connect to an expert, and we would connect people to their physically closest expert as well, so they can develop relationships that will help support them once they get going in their practice. So very popular, lots of engagement through these. Sarah herself has been conducting more than 100 interviews with these different stakeholder groups to understand really what their perspectives are and what's needed to advance this in primary care. And you recognize, many of you, the standard integrated knowledge translation wheel. We were completely astounded and actually delighted to find that when we invited people to our national monthly teleconference for co-investigators and stakeholders, that the CEO of SOGC joined nearly every month to talk about what their organization could do to help advance this practice. And similarly, the lead at Health Canada for marketed pharmaceuticals joined every month to find out what was going on and what was the latest we were learning from our platform and from our interviews, and had anybody identified health policy issues. And we spent quarterly, we would go face-to-face to Health Canada to bring our information. Sometimes they called us in to talk about things that they had come up, and also we were working with a number of provincial governments and the health professional regulators, the colleges that give the licenses to practice for both pharmacists and physicians initially, and now nurses and midwives across Canada. So what happened? We had more than 1,000 people prescribing or dispensing mifepristone who answered the surveys, and this is compared to 270 in the whole country beforehand. And Quebec hasn't started its mifepristone practice yet, which was half of the abortion providers in Quebec beforehand. So really, Quebec is just starting. They're very distinct. They have some challenges. And our platform was engaging lots of people, not as many as our surveys were engaging, which surprised me. I thought it would be the other way around. And the platform was identifying that it's more the people who haven't done abortion before that were using the platform. Very few of the traditional abortion providers were there. So very interesting. Among the survey, people answering the survey, who are providing mifepristone, 45% had never done abortion of any kind before. And we were able then to map, using the first 3 digits of postal code for people that were participating, what their locations were and relate it to provincial policies as things were changing. So first, BC and then Ontario, the license to practice colleges stood up to Health Canada's regulations saying the physician must dispense this directly to the patient. And BC's college stood up and said, no, that's not safe. We stopped that practice 10 years ago here. It's much safer to have a pharmacist dispense. They're the experts. Physicians don't know anything about this, and they wouldn't be able to enter anything in PharmaNet. We're not going to do that in BC. If you want to do that in BC, the physician's going to have to take a 6-month program and learn PharmaNet and become certified to be able to do that. So we found that the rural uptake in places where the pharmacists were allowed to dispense directly to women was hugely different. And you can see in Manitoba and Saskatchewan, Quebec and Newfoundland, where these things weren't allowed, there was very little rural uptake. And so these kinds of maps were great knowledge translation for the people going on. So really now what we're seeing across our national platform is that the majority of mifepristone providers are in primary care settings. Among all of our prescribers of mifepristone, 8% are in communities with no prior abortion service. We think that is roughly a doubling of the number of communities that had compared to that. So we're working on the maps right now. And that our work has appealed more to rural people than those in urban areas, which is exactly what we were hoping it would do. A bit of a timeline and about the policy impacts for coming down. And really, we now see that that list of 5 or 6 things we started with that were restrictive limitations that would make this hard in primary care, they're almost all gone, except for ultrasound. And in almost every case, we're able to make very direct lines to evidence briefs we've provided or engagement and discussions that we've had with the relevant decision makers in advance of the removal of these restrictions. So I love doing this. Just give me a minute. And as you can see, the big remaining barrier is mandatory ultrasound, and I'm absolutely thrilled to share with you the secret that I was brought by Health Canada last Friday to Ottawa to discuss removing the restriction requiring an ultrasound before mifepristone is dispensed, which has been a major problem in rural areas from our research. So we really were able to conduct highly effective health policy and services research and change literally dozens of provincial and national regulations and policies that improve the ability to reach out in the first instance contraceptive and now also abortion care to those who are where they're at. And to make more equitable access. And this is because we were able to engage all the right people to sit down and talk about what is the problem and to come up with potential policy solutions in this most recent case of providing primary care abortion. And we're in a politically favorable climate. So we had a federal government that came in 4 months after mifepristone was approved and a year before it became available on the market, it supports the ability for women to access appropriate care and was very supportive of the people at Health Canada and other decision makers we worked with. So we had a policy window that helped us to achieve the solution that had been created. Great. So now abortion is happening in primary care in Canada, and this is unique in the world, our area of regulation and the degree of primary care uptake. So There we go, 45 minutes. Sorry about that. I might go over a little bit. Then in summation, I think there's no doubt at all that we have gender inequity with relation to sexual and reproductive health, and particularly the ability to control the fertility as people would want it controlled and to reach their own fertility goals. There's inequitable access to both knowledge, services, also to methods to decide whether and when you would want to become pregnant. Those who are already disadvantaged are increasingly disproportionately affected by these problems, and we aren't going to be able to fix it until we can measure the indicators to be able to support not only the development of policy, but also the monitoring of the rollout of population health interventions, which we aren't doing right now. Free contraception would be a clear cost-effective health policy intervention, I think anyway. We have a range of partners, and I haven't even given you a portion of all the names of the phenomenally committed and bright people. Our new research coordinator, Kamal, is here with us, and many of our staff. Actually, can I have our CART people stand up? People working, helping with these different projects. Yeah. So I brought a cheering section just in case none of the rest of you clap at the end. And a range of decision makers and partners across Canada. So thank you for the chance to be able to really share with you my dreams and some of the really exciting stuff we've had a chance to be able to play around in.